Good afternoon, everyone. Welcome to Grand Rounds. My name's Tom Forden. I'm the chair of Grand Rounds. It's nice to see you. Thanks for choosing to be inside rather than outside in the glorious sunshine that we're having. I do like Scottish summer. It's my favourite day of the year, as they say. But it's the weather will continue. I'm told that I must not mention the football, but what about the football? It's such a shame for the Germans. Apologies for any Germans in the audience, but what a shame for the Germans. Somebody said to me this morning, what's the German for Schadenfreude? I think that probably says it all. So, last semester, we had our first ref showcase where Tim Langs came here and talked about the research that happens across in the medical school, the MRI, is having impact locally, nationally, internationally in terms of international guidelines, mostly speaking about the cardiovascular unit. The new interim dean, Rory McCrimmon, has asked me if we can have a slot every semester for similar cases. So I'm very pleased to welcome and introduce Chris Barrett, who's the head of Division of System Medicine, who's going to talk about a similar ref case, but in the sphere of assisted conception. On you go. Thanks very much.
Great. Okay, so I don't think I have any significant conflicts of interest which would change what I'm going to tell you today. I'm a fully employed member of the University of Dundee, etc. So what I was going to try and talk about today is the research or the work that you do in male fertility or male reproductive health. What difference does that actually make, and how can we quantify that difference? So rather than just publishing a paper and everybody getting excited, what difference does it make to the planet? So what we have been trying to do is formulate a pathway, an impact around male infertility. Now, I think it's fair to say that this is, at the moment, work in progress, rather than we've actually achieved the impact that we think we should. So I'd welcome sort of discussion and thought process about that. But when you're trying to think about work in progress, the idea is that it's a significant effect. It doesn't just affect people locally in Scotland, it affects the planet, basically. And that's where you're trying to sort of have an impact. You need clear evidence of that impact, and in theory you need a defined contribution. There could have been a lot of effect, but it needs to be attributed to, for example, Dundee. So where am I going to go? Well, the first bit, I'll just generally quickly introduce you to infertility, in case not everybody's familiar with that, and particularly the contribution of the male. And then I'm going to discuss briefly the World Health Organization, because that's really where the impact, the case that we're discussing, or we try to discuss where we will go. And most of that is working with the WHO, but a lot of it's working then extra to the WHO. So I will isolate what I think are 4 themes to this impact. One is the new guidelines for the diagnosis of male infertility, and that's funded by the WHO. Standards in male reproductive health. The WHO reference ranges with limits for the what we diagnose as fertile and infertile. And where in the future are we likely to go? So as a bit of background, everybody thinks that this is the result of trying for a baby. The reality is that this doesn't occur all the time, and approximately 1 in 6 to 1 in 7 couples have what is defined as infertility in reproductive age. What that effectively means is that it's an inability to conceive a child within 12 months of trying. And just for the reminder related to reproduction, what happens is that actually about 100 million sperm are inseminated into the vagina. It's unknown how many sperm get into the uterus. There's probably about 100 or 200 get into the oviduct, approximately. And then hopefully fertilization takes place. In this cartoon on the right, this is what happens in vitro fertilization, which basically we add a large number of sperm, usually around the egg. It's about 100,000. So normally you would have, say, 10 or 100 in the oviduct. We would then be adding 100,000 sperm or 50,000 sperm to the egg. Hopefully then the eggs actually then get fertilized by the sperm, and you develop an egg in vitro, an embryo in vitro. What I've placed here is this is what I term the abnormal way to produce children, and this is the normal way to produce children. And the reason why I've flipped it the other way, apart from to check that you're awake, is the fact that actually now, in some countries, this is 1 in 10 children are born using this technique. And in the United Kingdom, there were 72,000 cycles of IVF ICSI in 2017. And IVF ICSI is a $1 billion industry. So it is not a small beans. Of course, adding sperm to egg is done in a laboratory, and this is Philip and Sylvia discussing which egg to select, which sperm to select, and that's actually what happens. So if you've got 100 sperm, Philip or Sylvia or another embryologist dressed in a bunny suit will actually pick which sperm goes for the egg. And that's a big difference to evolution. In evolution, there's a bit of a race, you presume, and there are approximately 10 or 11 million babies in the world born currently by IVF. And what you would think is this is the classic romantic view of fertilization, and perhaps that's slightly less romantic view of fertilization and embryo development. So, as I mentioned, subfertile couples is about 12 months is usually the definition for unprotected intercourse. Increasingly, the major reason for referral and the primary single factor in referral for infertility is male infertility. You only have to open the press these days to sort of see about male infertility as the headlines, for example, and this is a term that I think Sarah helped develop, spermageddon from Armageddon, basically why the human race could be infertile in 50 years' time. And the reason why, for example, as a background that this was picked up, is that this is the graphs related to sperm concentration, the amount of sperm in a sample, and this is regards to the year, so this is the 1970s, 1980s, 90s, 2000, 2010. And this lovely little graph shows that it was about in the 1970s and middle 70s, there was about 99 million sperm per mil on average. And in 2010, it's 47. If you follow that graph, hypothetically, if you follow that graph, by 2040, we're going to be in a very subfertile, if not the zero range. So the idea is that men, and not necessarily their sperm, will be gone, and therefore this is added to the sort of discussion about male infertility. So, where is the impact, and how am I going to describe the impact that we're trying to have in Dundee? So I'm going for 4 themes. One is the new guidelines, new WHO guidelines in diagnosis of male infertility, and I'll talk a little bit about those. Then I'm going to deal with standards in male reproductive health, WHO reference ranges, where does the future lie? So if we deal with number 1 first, this is I think probably the most important impact that at least at this moment in time we can say that we're having. So for example, the World Health Organization has guidelines on how you're supposed to diagnose infertility. They were produced in 1992, and particularly ones for the male in 1993. If you can remember that far in time, this was a mobile phone in the 1990s, if you were born in that region. So now you can get, and the internet didn't exist, so now you can get a feeling for how long ago it was that the WHO last updated their guidelines for infertility. And in fact, these guidelines now still stand, because there are, at this moment in time, published no new guidelines as yet. So they're quite old, and they needed to be updated. So the starting committee for the WHO for the guidelines for infertility was assembled in January 2012. Contains eminent people and not including myself, but basically Bart Fauser and Paul de Vrooy were the chairman for the WHO for the starting committee, and then of course the committee then has to work out what they're going to do for the WHO. So and this is the outline for what they did. So bluntly, what they did first of all was come out what themes do we need to change, or what themes do we need to have for the diagnosis of infertility. And they came up with originally 28 areas, which is completely unworkable. So it turned out that we came down to 6 areas. One of them was male factor infertility. And I was the chairman of the evidence synthesis group, appointed in January 2012, and basically from then we went through the whole process of the WHO of how you develop guidelines for the diagnosis of infertility. So my job was the male, and there was 5 other groups: treatment on IVF, female infertility, PCOS, etc. So we met and Skyped, etc., etc. So, and then we went through the whole process. We then submitted those guidelines, which is a very significant document, to the WHO in September 2015. Hopefully, the WHO will publish those guidelines quite soon. What were the questions that we addressed? Well, what might surprise people who are perhaps less familiar with infertility is the very basic nature of the questions that we possess. We were talked about. One is, how many people are infertile from the male? What contributions the male give? Should a man, or if they do undergo an investigation, what is the nature of that investigation? And the example that I would give would be, normally it's recommended you have a history, you have a physical examination, and you have a semen analysis. That's simple. They've been going since the 1950s. But it turned out that actually when you looked at the data, most people didn't do a physical examination. So therefore, where was the evidence, as an example, that you should do a physical examination? What was the value of semen analysis? The IVF people in the audience will suggest, semen analysis is not that important. So where is the evidence that semen analysis is important? What lifestyle effects affect men, and therefore how can we advise them how to deal with that? Obesity, smoking, temperature, or the usual. Is there any treatment for the men? And the reason why this came up in diagnosis was the fact that these are very, very commonly used in assisted conception and in infertility clinics. Go and buy vitamin E from Boots, it'll make your sperm swim through concrete walls. Where's the evidence for genetics, etc., etc., etc.? So we went through all of these, and it took quite a lot of work, I think it's fair to say, to do these in a systematic manner. So these were presented in 2015. I was chairman of the group, so I was labelled with presenting it to the committee, and it was something like a 400 or 500 page document. So I won't go through that document with you today. But we published a review paper related to that in Human Reproduction Update. So they are the members of the committee. This is the WHO representative, and these are people from all around the planet who basically came together to do the diagnosis of male infertility. What we put here is the evidence to support our recommendations, what challenges, what future evidence is available. So it's a global WHO guidelines for male infertility. Just to very quickly summarise where we got. So, for example, what is the prevalence of male infertility and what are the proportion of infertile men? The most remarkable thing for me is we didn't know that. In many countries, nobody got a monkey's idea, not a clue how many people were subfertile in that population. Is it necessary for all men to undergo a thorough evaluation? The answer was yes, in that it's physical examination, history and semen analysis, but that was it. That was the only things. In fact, physical examination was very tenuous, I think. What is the value of semen analysis? And that came out as quite valuable if you put all the parameters together. And you'll notice here there's a comment on the strength of the evidence, and this is deemed to be evidence-based medicine, and it's done through the WHO. What you'll notice here, there's often it's low or very low, and that was a very significant theme. And in fact, when you look through all of the data, the most remarkable thing that came to us as a committee was the fact there was a lack of high-quality data to produce any real hard conclusions on many of the questions that we asked. And in fact, we were tasked with another 7 questions, which are impossible to answer because there's hardly any good quality data. Lots of publications, but not quality data. In addition to that, the professional guidelines and recommendations were incredibly helpful. There was no evidence that actually they worked very well. So when, for example, they were discussing the ASRM related to their screening of men for endocrines issues, the evidence that those were working well was actually very low. And the theme that came round in the last example I'll give to you towards the end of the talk was related to where do we go? If this situation is so bad, what are we actually going to do about it? So, the outcomes of the so far for the guidelines were the guidelines have yet to be published. They're stuck with the lawyers at the moment, and the WHO and the lawyers mix quite like treacle, and therefore it's completely uncertain when the guidelines will be published by the WHO. The paper's out, but the guidelines are yet to be published by them. The question then becomes, is there any effect on policy, even though they're not published? And that has been quite significant, so I'll give you an example. MRC, NIHR and the EME basically looked at the guidelines, looked at the papers that we'd done, and realised that there needed to be a call for the treatment of male infertility, because there was no treatment for male infertility out with ART. And that would be an example of an endpoint, for example. But the WHO recognised that actually there was some very key issues that they needed to deal with. One is the very poor quality of semen analysis. One was they need another semen analysis manual, because the one that they're currently using is actually difficult to follow in some aspects. And there needs to be new reference ranges for male infertility, because the ones that we currently have at the moment have very, very minimal biological and hard data to support them. So, now dealing on to number 2 theme, which follows on from the WHO analysis. What about the standards in male reproduction? And this is very, very important, because what we really need to understand here is that actually in clinical terms, a semen analysis done, say, in Dundee versus Darlington versus Durham, North Carolina, the only thing you could probably guarantee if it was the same semen pot is that you get a different answer. And that is just crazy. Any normal living human person who walks the planet will tell you that's a nutty situation. And this is done, this is NEQAS data, which is from the UK. And basically what this means is send out a pot of semen, split it up, all should be the same. You're either coming in as oligozoospermic, i.e. you need ICSI, IVF, 6,000 quid a shot, or here you're a sperm donor, same sample. So that's a bad place to be. And the WHO have known this for many years, they've just done nothing about it. Now that makes a big difference to patients. It's a very big issue for patients on the street. But it's a really big problem also if you're trying to develop a guideline. Because if I'm trying to work out if obesity affects sperm counts, how can I do that if I can't trust the sperm count? So it turns out that if you look at the data in the literature, how much of this data is actually quality control for semen analysis, where you could believe it's in the middle rather than on the outside. And it turns out that not a lot is the answer. So with the blessing but not the funding of the WHO, we decided to deal with this process by producing guidelines for journals on the publication of material. So this paper is as an example, very, very simple title, How Do I Count a Sperm? Not complicated. So most people on the planet could hopefully follow that, hopefully. And we came up with basically a checklist. So if you want to publish a paper, we're using sperm counts or using semen analysis data, follow the checklist to give us an idea that the quality of the data is good, or at least if it isn't good, we know what the error is, which is equally important, and we can then make conclusions. This was obviously a no-brainer, and obviously all the journals would accept that. That's not true. The journals hated the idea of doing it, and the reason why they didn't like it was when they piloted this, most studies didn't comply, so they couldn't receive the paper. So that caused a bit of an issue because the number of papers would have dropped significantly to the journal, the income would have dropped, yada, yada, yada. So it turns out that although we thought this was a good idea, logically everybody's happy with it. It happens in other disciplines, they have no problem with it, but clearly IVF does. That actually many journals completely rejected the idea. So it's only the ESHRE journals currently, which are the most cited journals in reproductive medicine, who actually use these guidelines. So this is a bit of a question of how to know to do that. And so far it's had 26 citations since 2016, so in the impact journal of 5, that's actually quite a bit above what it should be. But it should be 260. And that's, I think, a significant problem. So we carried on the crusade, so to speak, about the reproducibility of male infertility, reproducibility of reproductive medicine, and we set up a Capri workshop through ESHRE to try and sort of say how good is quality of research in reproductive medicine. This is a common theme in cancer, every other disciplines, but reproduction had not taken it on. And you can guess from the title what the conclusion we came in. And this is from the Institute from Stanford, where we work with them. And what it basically says is there's lots of issues that we need to deal with. So that is theme 2 that we would suggest. Theme 3 for the male infertility sort of outcome that we're looking at is reference limits. These are absolutely fundamental to male reproductive health. What this really means is that actually this is how we diagnose men. And that's a fundamental thing. So the WHO and with our recommendations were that you need to do another manual, another semen analysis manual. Previously, they had one editor and a bunch of co-editors, and that clearly didn't work well. So this time we suggested we'd have 6 editors, and then we'd split the tasks up between us. So I'm one of the 6 editors, and we're splitting the tasks up. But the reference ranges are really what people are interested in, i.e., if I get a sperm count of X, and it's believable, what is the man? What is the difference, and where does that man actually go for the pathway? So this is the same analysis manual that's currently in, is 2010. So it was published 2010, and already it's at 7,000 plus citations. So it gives you an idea of the influence of the manual. Apart from being in every andrology, every lab that does semen analysis on the planet has a copy or electronic copy of this book. So currently the WHO reference values of 2010 are a sperm count of 15 million. So if you have below that, you're classed as abnormal. Above that, you're normal. And motility is 40%, so 40% of your sperm are moving, and 4% normal forms. So that means if a man is 96% abnormal, he's normal, which is always good to know. If you're on the abnormal scale, are you normal? That's happy. So that's clearly a bit of an issue in any type of reference range to look at that. They're only the lower reference ranges because at this moment we don't have time. Statistically, we know about upper reference ranges, but we don't know they have any impact. We know that these have some impact. But the problem with this is actually that the data from 2010 is actually really, really poor quality compared to what you would expect for reference ranges. And here's Happy Martin. So Martin's going to spend the next 2 months working with the WHO to actually develop new reference ranges, and I'm sure he's excited about doing that. Because one of the issues we had last time was that they moved the goalposts from 20 million to 15 almost overnight. So some men who were normal in the IVF clinic, suddenly they weren't normal anymore. And there was no biological data for it, or very limited biological data for it. So the quality was big questionable. There was very poor geographical representation, almost all white, Caucasian, usual story. There's very little representation elsewhere. So the idea is that we present the new data to the WHO in September 2018, and the concept is that we publish, hopefully, no pressure, the paper in March 2020. To give you an idea for citations, independent of impact for the planet, Trevor Cooper's papers had 806 citations since 2010. So actually these are well-used limits intellectually as well as, of course, practically. So what about the last theme? The last theme is very nebulous and very difficult to give any quantitation to. But if I was to ask, was it going to have a very big impact? I would say this is probably the biggest impact, but I can't justify it to you at the moment. But that's the question. So how do we change policy? So it seems to when we're doing the WHO analysis and talking to what's termed key opinion leaders, and of course that's a very subjective term, but the idea was that actually we don't have any roadmap for male infertility. Nobody knows what the future's going to lie. We don't have enough funding. We don't know what the problems are. Nobody's got no idea how to change policy, etc., etc., etc. We know it's important. We know it's a growing issue, but we don't know what to do about it. So somebody needs to pick up the ball, really, if you excuse that, and basically run with the strategic roadmap. So we decided to do that, because I haven't got anything else to do in my life. So I thought, okay, we should do this. So with the MRC in Edinburgh, and ourselves, and from the University of Minneapolis, we decided to put together a document on what should be the future for male reproductive health, how we get there, and what we need to do about it. And between us, we came up with the term man up. I don't like that term, but I was democratically outvoted. But the concept is that this would start as a blueprint to try and change what we do for male reproductive health. What we suggested was actually we need to identify what the fundamental research gaps are. That's not too difficult because we've already done that through the WHO, so we can cheat a bit in doing that. But we need to incorporate industry, policymakers, etc. I've done that previously with the HFA, and it works really well when everybody's on board. So hopefully that will work okay. We develop our detailed roadmap. We then mobilize strategic funding sources, and we formulate policy. This is for the planet. So this is not for Scotland or the UK or America. This is for planning to do for all of the world. So a collaborative effort is required. Everybody I talk to at the moment suggests that that should be done via societies, Society for Reproduction or Society for the Fertility or somebody. They all want to do it, but no, they just want the title. They're not going to do anything. And all they talk about is they just yap between them and they don't do anything. So I don't think that's not going to work. We have to just get on with it. So with the roadmap, this is the hard bit. I've talked to policymakers and people who've changed policy historically, and I think this is the best example I got from Chris Tyler, who works with the UK Parliament. What he suggested is just getting evidence you need to do something. It's just not enough. Telling the policymakers there's a problem isn't enough. What you need to give them is doable changes that they can happen and they can quantify. And the example he gave to me was smoking and how difficult it was to change policy for smoking, for example, even though you've got evidence. And this is a quote that is basically stick on the wall. To truly inform policy, it's not enough that you hope the stars will align. You've got to make them align in the right way. And I think that's the key bit that we need to try and do. At the same time, and fitting that trying to change things, I think we need to marry it up with a male reproductive just health and health in men in general. So, for example, Peter Baker and Tim Shand have gone through what are the policies in the world for male health. Is there any governments that have policies for male health? Is there any in the world? Turns out there's only 3, Australia and Ireland. And that's a significant issue. Lots that have policies, issues for women, but not specifically for men. But in again with that, we thought we could also map it quite bigger than that. So we've mapped our plan to the Strategic Development Goals of the United Nations, and we've stuck what we think is a big thing in the middle, which is basically family planning. So we got this in discussion with the Family Planning Org, and basically if you change family planning, and you improve family planning access and development, for example, you can address many of the strategic development goals for the UN for 2030. So when we went through this document and we were talking to the people, everything seemed really exciting and happy, and everybody seemed to be on board. And their family plan in 2020 are trying to change by 120 million users by 2020. It's their progress report. They're not going to achieve it, but that's their plan and funding from Bill Gates. The biggest problem with this document on family planning is that actually there's no men. So last time I looked, you need men and women for a conception. So basically not having men in there is a fundamental problem. So our plan is to put men into this particular approach. And I think that will make a bit of a difference. So male contraception and how you deal with the male health will be an important thing. Don't forget there's been no development in male contraception since the condom. Vasectomy is deemed to be non-reversible. The condom was originally developed, so I'm told, in history, quite some time ago in 1400 BC. So there hasn't been much change since 1400 BC. It's about the same time as Wales trying to win the World Cup as it's going, but anyway, we won't go there. So the other question we have is what are the costs of male infertility? And that's a big issue that I think we need. If we put a dollar amount to this will help us in developing our policy for the male reproductive health. Because at the moment, if I was to ask scientists around the medical school or clinicians around the medical school, what is the cost of their particular disease, they could reel that off just like that. And the reason is they write grant applications. That's almost, A is what is the prevalence, what's the cost of it? I don't know the prevalence, within reason, you can guess. I have no idea the cost. So automatically we're on the back foot. So economics are fundamental to this issue. So what progress are we doing since January 2018? How are we getting on with this? Well, we're doing a roadshow between us, happy chappies that we are here. This is Alan Pacey from University of Sheffield, who's an outstanding sort of communicator on science. Sarah, Richard Schaff from MRC. And this just is an example of one of the roadshows that we've been doing. This is for the Scottish Government, and it's basically trying to change male reproductive health. And this is basically what time waits for no man. So it's trying to work out what male health, male age, would you do assisted conception. So we've done presentations to the Science Media Centre, etc., etc., etc. So that's what we're trying to do to change things. We've set up an andrology Cairo consensus conference to try and deal with the diagnosis of the male, to push that forward. We've contacted and we're in discussions with Wellcome to try and get funded an initial meeting where we would try and push the strategic road back harder. And basically NIH have verbally agreed to do this as well, but they haven't signed the financial check yet, but they verbally agreed to do that. Industry and societies are happy to help, but they don't want to do any of the work. So that's a question for us. So my last slide comes to basically where's the evidence that Dundee is making any difference to the planet in male reproductive health. And the way that I think we should go at a case report, but of course we can have a ref case report, would be basically related to our work with the WHO. When you do a case report, it needs to be rest of the world. It needs to affect the world. It can't just affect your local region. So basically, I think that's our starting point. The guidelines have yet to be published, and I think that's a bad indicator, because if they're not published, we'll have to revamp and re-look where we are. But basically, they're not published in the full form. They're only published as a paper at the moment. So that's a question I think we have to work at. We have to work out how many other people have changed policy and developed guidelines related to funding. So EMI and MRC is an example we could give. NIH is an example that we can give. But are there other examples that we could do? The international recommendations for publication of the policy. So you've got to do a certain amount of tick boxes to get your paper published. Good idea. I'm sure it's great. But I think the political challenges of this are just too big, I think. The WHO new reference ranges for same analysis, I think that will make a massive difference. That is the universal thing through any lab throughout the world. That's what they use. And I think that's what Martin will hopefully come up with, different biological data to support those reference ranges. I put the last bit in italics because it's something that's a bit nebulous, a bit difficult for us to quantify. So I'm trying to quantify it to Rory. This is what we've been doing and this is our impact. At the moment, I think what we've done is spent a lot of ATP and we haven't perhaps achieved much. So I think that's what we've got to do is in the next wee while. So we've got to try and achieve as much as we can related to that for the end of 2020. Thanks very much.
Okay, I say this a lot, but coming to Grand Rounds every week, I find it most interesting when I know absolutely nothing about the topic and I learn. My learning curve is very steep, and this is certainly below the diaphragm, so I know diddly squat. Has anyone got any questions or comments they'd like to make? Anything they'd like to say?
Thanks, Chris. That was great. Just a couple of questions. One is, I don't know if it's answerable, is about, do you think there's a subjective bias against funding male infertility relative to female infertility?
Yeah. So if I can address that head on. So I thought that, and everybody who works on male reproductive health thought that. The difficulty is that we don't have the data to support that. So I contacted NHMRC and MRC in the UK, one Australia, one in the UK, to try and see what the pattern is. It turns out that actually related to female infertility compared to men outside of cancer, this is just reproductive health, that actually the funding related, the proportion of grants that were deemed to be quality, i.e. went through triage, and then were funded, was equal. What the problem is that the number of applications that they get is relatively low compared to the discipline, and secondly, the quality of the applications they get is generally poorer, and that worked in both Australia. It's difficult to get harder data for NIH, but they assure me that it's probably they verbally say it's a similar thing. So both MRC and NHMRC say there is no bias against it. It's just that you guys, A, don't put enough in, and B, what you put in has got to be good quality. And in fact, actually, the ones that then have gone through triage to be funding, there's about an 80% chance of getting funding, which is actually quite good, in that part. So, yeah, I think everybody thinks there's a bias, but actually, when you look at the data, that may not be so.
And just a second question, the declining sperm count, do you think that is on a straight line trajectory, and is there any endocrine basis for it, do you think?
Yeah, so I think if I'm writing a grant, it's obviously absolutely correct. The planet's going to be over. We need to do this instantly. I think the data, strangely enough, for sperm counts is much weaker than everything else. So, for example, you look at cryptorchidism, testicular cancer. The data for that seems to be actually much stronger, i.e. the increased risk of testicular cancer, controlling for the diagnosis. So the hypothesis is that there's something clearly up with this testis, and it's responding negatively to either genetics, the environment, and or above. And the prevailing idea is it's related to the testis in utero. Now, it was previously thought, and Richard Sharp was one of the people who pushed a lot of this, was that basically it's the likes of phthalates affecting androgens, etc., and that's having a big impact. That, I think, is less clear now. And what they're thinking now is that actually it may be toxins that are in the environment that are affecting the testis in utero that may not be just a purely endocrine mimic or endocrine effect. But I think that it's fair to say we don't know the answer to that. And one of the difficulties is there's a group in Copenhagen which basically say the story solved, this is the answer. And while that's interesting, it's not intellectually rigorous, and that's really biased the field quite a lot. So I think it's difficult to make a high conclusion on that. But the sperm and the other issue is that most of that data comes from Western countries, and that's a significant problem. So yeah, complicated answer, I'm afraid.
Why can't we count sperm? That would seem like a relatively straightforward thing. We can count red blood cells.
Yeah, I know what you think, wouldn't you? You better ask the people.
Sodiums.
Yeah, no. So that's a bit of an issue, really. So when the medical students come on the course for reproduction, they're generally absolutely amazed that we do it manually. So that's one issue. Can we not have a computer to do it better? And that's clearly an issue. The second thing is that actually the technique for doing it is a bit laborious. So most people don't bother. I mean, I could give you a long answer, but that's actually the issue. So when and I used to do this quite a bit, I used to go on run courses on counting sperm. People came from, all different places. They're andrologists counting sperm. They turn up at the course. It was a war zone. They didn't do A, B, or C, and they've been doing it for years. And they don't because they say, there's 100 million sperm, and if I get 50 million out, what does it matter? And it's just bizarre.
Presumably, if there's zero, you're pretty confident there's zero.
Within reason, yeah. Once it's spun down.
I'm asking for a friend, obviously.
Yeah, no, absolutely. So no, 0. I think zero's generally a bit easier to deal with.
Super. Anyone else got any questions? I think this kind of stuff's fascinating. As I say, the only interaction I have with you guys and the fertility services with my CF patients, because they have congenital bilateral absence of the vas, so they come across for ICSI. So I know a little bit, but it's really good to expand the knowledge below the diaphragm. So thanks very much. There will be more of this sort of thing from the MRI in the next semester. Next week, an amazing opportunity to hear an international expert on something unusual. So Oriol Shibali is from Barcelona, and he's a respiratory physician. He's overdoing an attachment for 3 months with Professor Chalmers in the bronchiectasis lab, but he's an extreme athlete, Ironman triathlete, He's climbed Everest, and he's going to come and talk about the responses to hypoxia while climbing Everest. So he climbed Everest and took blood gases, so we can see what happens to blood gases in extremes of exercise. He's a very interesting guy, so please do come along. That's next week. So thanks so much, Chris, and thanks for coming. See you next week.